So I'm Gemma, I'm the ward manager of Giffard. This is Jo, she's a HCA, Abby is a deputy sister, and Nikita is one of the TNAs that will be qualified in September. So, right. So our presentation will be a little bit different to the one that Juliet's seen because things have developed in the last 3 months and we're trying not to waffle as much. So we're going to look at who we are as a team, what we feel we do well, the previous SCAPE audits and how we've achieved the recommendations, and also look at a couple of areas that we feel that we excel in. So if you don't know Giffard, we are currently a 16-bedded surgical ward. We take colorectal, urology, ENT, breast surgery. We've taken, in the last 18 months, a new speciality of oncology, and we take an MDT approach to all patient care. We work closely with consultants, dietitians, physio, OT, discharge planning nurse. We're compromised. There's 30 members of the team. We have registered nurses, associate practitioners, HCAs, NAs, our ward clerk, but we also work closely with the domestics and our kitchen assistants. We are an active student placement for TNAs and nursing students and dietitian students today. We have retained our agency staff for the past 18 months or almost 2 years, but we are coming up to the time where in 2 weeks' time we will be agency free and we are fully established.
So on Giffard we have a positive learning environment and support lots of all members of staff. So we've got 5 members of staff that have recently completed their care certificate, and those are supported with a coach in practice. We also have 2 completing their VQ awards. Jo here is completing her assessor so that she can assess those in practice. Nikita, as we said, completing her nurse associate, and also we've got newly qualified on rotation with us. We've also got Gemma and Nick doing their degree conversion in the next few months. We encourage our Band 5s to coordinate the ward on a regular basis, and all our Band 6s were previously Band 5s on the ward, so it just shows us that element of progression for everybody. We give staff their ownership and responsibility of their own learning, so with regards to their education records, and there's also a link nurse to support them with that role. We encourage our unregistered staff to complete physiological measurements and also support the surgical journey for patients, so taking patients to theatre as well. Jo?
Me. Myself and another member, Helen, have just completed an Ergo Coach course, which was 5 days of manual handling, which means that we can teach staff members on the ward rather than going for a day. We're able to train colleagues on equipment that's more specific to our ward and to deal with any problem patients that we have. We keep a folder with all the training records, a quick reference wall chart, completion, and it's all the standards set by SCAPE.
We also split our ward into 4 teams, so each team each month is in charge of either the audits or a notice board for staff education, patients education, and also helping with the audits on the ward. So that allows everyone to get involved in all the different processes.
And a training, and put on a training session for the rest of the team.
Oh, that's me again. So
that's Abby there.
Despite our large turnover of staff, we've helped with the recruiting through social media and also through volunteering at job fairs. This just helps to put Guernsey on the map and show the nursing opportunities that are available. When recruiting, we not only look for surgical experience, but those with the medical background to help expand our knowledge and improve our teams, basically. We've got some long-standing members. Jo got her award this year for over 10 years. Is that right? 10? 15 years. But yeah, many members are 10 years plus.
Okay. So as a ward, we like innovation. So we were the first acute ward to have a deputy sister, which we feel that helped achieve SCAPE because it gave us more leadership and it allowed time for us to spend having one-to-ones with our team so we could resolve any issues sooner, know what they wanted and work with them. Also, we moved wards. We were on Brock Ward, we moved back last May to Giffard, and we were involved in the process of moving, which allowed us to model the ward to suit the patients that we have. I mean, we couldn't put walls in, but we could give some input. We also were the first to have the dementia-friendly signage within the main hospital. Our toilet doors are a lovely cerise colour with a big toilet on them, and they've rolled that out into A&E now, and they're trying to roll it out throughout the hospital. We also have good feedback on our recovery enhancing colour scheme. For anyone that's seen it, in the main bays it is green, which is very calming for post-operative patients, and then they moved out to purple bays, which is very uplifting and help with recovery. Also, when we moved, another thing which helped with budget control is we managed our stock. We went through, it took us a long time, but we went through everything, labelled everything. It helped with the ordering process and the budget managing side of it.
So this is an example of a few good practices we've done. So this is Emily, who got nominated for Nurse of the Year last year. We've got Tanya showing us we got 70% compliance with the new DFib in the hospital. And this is the toilet sign that Jim was on about with our dementia friendly.
Sure again.
Our ward charter is We Care, and it's been not painted, is it? A sticker?
Yeah, it's very big. As soon as you come in the ward,
You can
on
see.
the right hand side for everyone to see.
Yeah, it's just really so staff and patients know what kind of care we give. It links to Service Guernsey with the aim of delivering services centred on those that use them and improve customer satisfaction. And you've already mentioned creating the team building days. We will attend to hope to create the charter which will revolve around this.
We created this one as a team, and we wanted it to be our promise to our patients and their friends and family. And so we have that for everyone to see, but then we thought we haven't got one for our staff, our promises to each other. So we want to come up, we've booked a team away study day in August, and then we have another one coming up in October, and we're going to talk at that about team values and what we all think and come up with one as a team. Okay, this is me. So SCAPE. We've been awarded Free Green, which then we went on to get our Blue SCAPE. In 2016 we got 18 recommendations. In 2017, 18, and 2018 we got 7. When SCAPE first came out, we wanted to embed it in everyone, and so people were afraid at first what was SCAPE. So the Band 6 gave a presentation on what SCAPE was. We have a display on our board. We also do some mock SCAPE. One of the Band 6s will go and do a mock SCAPE, and then we can see the areas that we need to improve on, so we know which areas we need to improve. So 2016, I've taken a couple of recommendations from each. So it said that all staff needed to attend a pain management course. So to overcome this, we booked more people on, because obviously there's only a limited amount, but we ensured that that was protected time. So it's highlighted on the off-duty who's on a study day. So if extra help is needed on the ward, they'll know not to go to those people, they can look at others. next, the medication within date. So we went to pharmacy, and to clarify, was it our role, was it their role? And it was our role. So we now have a monthly check, and we give staff time. We give them a 7.5 hour shift each month. We rotate it through the teams, and they do all the audits, including stock check, and they go through the medication cupboard, everything, to ensure everything is in date. Patients have discharge started on admission. So at this time in 2016, HSC was bringing out the new paperwork, which included more about discharge on it. So we worked together with the PDLs, learning how to use the paperwork. Also, we have a very close relationship with our discharge planning nurse. We also have a whiteboard on the ward, which we designed. We had one on Brock, and we got one for Giffard, which, when we have whiteboard meetings twice a week, it has the patient's name, and then we highlight if they need support, if they have the input from that team, like physios, or if they've been discharged, and it enables the whole team to see where a patient is in their journey. 2017 SCAPE, so the recess trolley. We managed to overcome this action by ensuring that we added it to our daily checklist, and we allocate staff on the off duty every week, so the person can see on the off duty that they're due to do the crash trolley, and I believe this has helped all staff to have an annual appraisal. So as Abby was saying before, we've split the teams further. We used to have 2 teams with 2 band 6s in each overseeing them, but we split them down further now, where we have 4 teams. So everyone on that team knows who they're responsible for, and the person, if they're due their appraisal, they can go to the person. Protected meal times were not visible. So we've achieved this, but the way we've achieved it is that we don't have protected meal times, but we have patient-centered visiting times, which allows anyone to visit the patients between 11 and 8. We are flexible in different cases, but if a patient requests protected meal times, then we would honour that, but it allows people that want to help their relatives or friends come in and feed them. It allows them to be on the ward at those times. So in our last SCAPE, we had 7 recommendations. There were a few around continence, which at the time the continence nurse was new into the role, so she's been very proactive. She's been working with the community urology team and specialist nurses. She's attended training, she's put training on within the ward. Also there was one about staff aware that a root cause analysis is required for a pressure ulcer stage 3 and above. We have asked the tissue viability nurse for more training on the ward, and we've also put an information board up right where our dressings are, so everyone can see that on the way. And then 50% of staff have undertaken some level of end-of-life care training. As I said, we will talk about this palliative care more. We've taken this on, and it's something we've become passionate about, and we work quite closely with Liz Dorry, and she's put on study sessions on the ward, and we've had one of our palliative care link nurses done her degree module. So we are developing in this area, and since November I think 11 people have attended an end-of-life study session, so we are achieving that. We will have achieved that. So
the pre-admission clinic is one of our own initiatives which we started last year. So we do this by asking the patients to come in for an appointment during the week. We get their notes up during the week and get their paperwork ready, and then at the weekend when we don't have elective surgeries, they attend the ward. And this just allows us more time to spend with the patient, so it helps with build that staff-patient relationship, and helps address any issues prior to the admission, so that we can aim for a smooth discharge and highlight any specific care planning needs. prior to admission, and it seems to work effectively. Patients seem to really appreciate that extra bit of time, and it allows us to use our clinic, so it's a bit more private and confidential, not just a curtain drawn.
This is a bit about what Jen was saying before, where we've really focused on palliative care and end of life. So we've had really good feedback from different doctors and family, especially the oncology doctors. They said we're doing a really good job and they're quite happy, and I think they can now see the impact of the training that we've done. We have an active link role who has done her degree, which Gemma was mentioning before. She has also been able to put on training sessions with Liz Dore, so to get us all more up to date and more familiar. So that's our on-ward training we have. We've had them in syringe drivers and end of life, and we're looking at doing training on complex discharges. We have also done some facilitated reflective practice, as this is part of ESCAPE. We've already undertaken this a few times, especially when there's been difficult complications with the patients have occurred on the ward. We have done this with a palliative care nurse and the chaplain.
Going the extra mile. Some of our oncology patients have been with us a long time, and we had a little old lady that was missing her cat, so we had permission and her family brought the cat in, and it just curled up on her bed and went to sleep, and it was sad. And we had another man who was really missing his horse, and he was wheelchair bound, so we arranged for wheelchair taxi to take him to the stables.
I drew the line at a horse coming in. Unless it's a little mini one.
One of our patients who passed away, his stepson did a sponsored run around the island, and they raised money for a recliner chair for us to put in our family room, which was nice. It could be used by staff or any patients that want to stay over. We encourage day leave for the patients to go out if they're well enough with their families, for a drive in the car or for the afternoon at home, and get well dressed, get moving, and we encourage people to go to the canteen to have their meals with their families.
So going forward, we have our blue ESCAPE now, but that doesn't mean we're going to stop. We've come here today to highlight to everyone what we feel we're doing well and to get others engaged in the process. We wanted to look at ways of how we could get everyone involved in ESCAPE on the ward, so it just wasn't us. So Abby came up with a brilliant idea, and
so instead of having the current link roles, we've scrapped those, and instead each member of staff is assigned a ESCAPE link role instead. So each, obviously the teams are split into 4, and those senior staff nurses are in charge to make sure that the ESCAPE standards within their teams are reaching the criteria. Not only does the standards also set out clear guidance and structures for everyone, whereas the previous link roles were a little bit unfair and a bit uneven, so this should help with that process. We're also going to help make sure that more facilitative, reflective practice is implemented, because I feel that there's a lot that can be learnt from previous experiences. So to do this, we'll utilise the PDLs and obviously the other specialist nurses in the process.
We also encourage staff to go on a ESCAPE audit if they'd like to, so they get a better understanding of the process. I did that myself, and I found it really useful. And we continue to take on patients' feedback and learn from that. And we want to carry on developing and achieving. And that's us.
Right, do you remember
You're all right.
when you were in school and you did your English literature exams?
I have to do that.
There were set plays, and you know there'd always be a Shakespeare one, and if it were Midsummer Night's Dream, Macbeth. Is that a dagger I see before me? You know, Henry IV I did, To Be or Not to Be. You know exactly what's coming because they are so well known that it's almost automatic. I remember going to the Royal Shakespeare Company to see Midsummer Night's Dream with my youngest son, who was then about 13, 14, and he sat beside me quoting the lines as the actors and actresses performed on stage. And you'll see why I've called it set plays as we go along. I'm going to start generally and then home into a more specific area of acute pancreatitis. So, all doctors, but perhaps not so much nursing staff, are familiar, and Brian certainly is familiar, with what was the National Confidential Inquiry into Perioperative Deaths. It's moved on since its inception, more than 20 years ago, to the National Confidential Inquiry into Patient Outcome and Deaths. So you don't have to die anymore to be included in it. And last year, they decided to review the reports over previous years and draw out some common themes, which were quite interesting, but I want to concentrate on just one of those. Number 10. It's about policies, protocols, proformas, guidelines, and SOPs, standard operating procedures. And they highlighted, because NCPOD looks at case notes and asks for photocopies of case notes around particular conditions. And in their review of case notes, it frequently highlights that either there's no standard, or clinicians believe they exist, even though they don't, and they're working to what they think they are in their head, or they do exist, but they don't follow them. And don't we just know that with Polyplus? We've got all those guidelines there, and we just don't refer to them. So we've got a bit of a dilemma really here. They did put some definitions out just so that, because somebody will say to me, well, it's a guideline, it's not policy, and but actually there's a lot of overlap. It's some sort of standardisation really. So based on 14 reports since 2000 and 13,000 case reviews on all sorts of different topics, that the recommendation was that hospitals should have evidence-based policies, protocols and guidelines for the organisation and the delivery of safe care for patients in all areas of healthcare. And they should be kept up to date, be accessible to all staff, audited regularly, and augmented with staff training in how to use them. Yeah, and I know you will be familiar. We've got a few around, haven't we? We've got, where am I going here? MRSA, care pathway, yeah. We've got, I just took these from Giffard today, traumatic brain, head injury, neurological observations, C. diff, yeah. We've got an interesting one here, integrated care pathway for patients who undergo open colorectal surgery, plus or minus the formation of a stoma within the enhanced recovery programme. I would suggest that open and laparoscopic should be treated similarly, there's no difference. Central venous catheter for adults, says at the bottom here, due for review December 2015, we're a bit behind there. Integrated care pathway for parenteral feeding, no review date. And some of them, this is acute transfusion reaction, have got flow diagrams, and I personally love flow diagrams because I can see in a glance where my patient is and what I should be doing, as opposed to words. Yeah. And in fact, it's interesting because I just must mention this for Vicky. I first met Donald Berwick the year I was appointed as a consultant in 1990, and I went to Boston to study his healthcare programme, and we were taught how to do these.
How was I?
Yeah, you know, and which boxes to use and how to, absolutely. So, it's not rocket science, is it? Now, going back to the set plays, I'd like you to think about what you do every day, whether it's at home, whether it's at work. And I think you'll, when you think about it, you'll realise that 80% of what you do is routine. You do it day in, day out. You brush your teeth, you do the washing up, you get dressed. You come onto the ward, you have a handover, you do your observations. It's all routine. In fact, we ought to be able to do it with our eyes closed, and only 20% is offbeat. And if you think about it, if you totally standardise that routine, it would save you a hell of a lot of time. Instead of having to think each time, how do I do this? What should I do for that patient? What should I do for this? And it's the same with our patients. 80% present with the same conditions, and it's only 20% that are off the wall, in that they've got a bit of this and a bit of that, and they don't quite fit a picture. In fact, we've got one on Giffard at the moment. But if you standardise the 80%, it actually frees up time so that you can concentrate on those difficult ones. Yeah? So back to NCPOD. In 2016, Brian will remember this because we entered it here, they published a report entitled, you can't read this very well, Treat the Cause. And it's a review of the quality of care provided to patients with acute pancreatitis. And they came out with, as they always do in their reports, with recommendations. So what they do is they send out to every hospital in England and Wales, and we form part of that, the questionnaire regarding a particular diagnosis. And it could be for a year, it could be just for a month, or a snapshot of how we manage those patients. And it's a huge booklet to fill in, and Brian passes it on to us as clinicians. So we selected our pancreatitis cases and we sent our replies. And of importance is that you should expect, for a population of 300 to 400,000, that's an average DGH in England, 100 admissions a year with acute pancreatitis. The vast majority are mild and self-limiting. A few are severe, and these are the ones that sometimes die. It leads to multi-organ failure, intensive care, expensive care. So, in order to optimise care for people with pancreatitis, you need a timely diagnosis that it is pancreatitis. You need to assess as best you can whether it's mild or severe, so you know where to put your resources. You don't need to starve them too long. We're very used to starving patients, aren't we, particularly surgical patients. You need to manage their comorbidities and be aware that they might deteriorate. And you need to look for a cause. And the vast majority are related to alcohol excess or gallstones. And then you go on from there to try and prevent or minimise recurrence, because pancreatitis can recur. And the principal recommendations are that if you've got gallstones, get rid of them. In fact, there's been a very recent publication just in the last month to say that not only should you operate within 2 weeks, you should actually operate same admission, so that they can't possibly have further pancreatitis because you've got rid of the gallstones.
Is that the same for polyps as well?
No, polyps are a bit different. We can talk about that if you like. Gallbladder polyps, yeah. You should have access to specialist investigations, and we're actually very well off for a small hospital in terms of radiological, endoscopic and surgical intervention. We do liaise with Southampton or the Royal Free if we get really nasty pancreatitis. We should adopt early warning scores, which we do, and we should have access to high dependency care, which we do. And the bottom one, antibiotic prophylaxis is not recommended. And they say this because when you get acute pancreatitis, it's sore. There's a lot of inflammation going on. You often have a temperature. And time again, I'm phoned by the ward to say this patient's temperature is 38.3 and they've got acute pancreatitis. Would you like to start antibiotics? And I say no. In fact, there are more people die if you give them antibiotics than if you don't. But it's difficult, isn't it? Because when you're phoned up, you're on the end of the phone, should we give them or not? Well, if I give them, the nurses won't bother me anymore. So I'll just give them. Because it's in my head, I haven't got the guidelines. So, very simple. We go on to specifics of acute pancreatitis. Initial assessment, like everything, history and physical. Baseline blood tests, which ED always do for us. And the diagnosis is only acute pancreatitis if your serum amylase is 3 times normal. We spelled amylase wrong. I'm looking at it. You just see that, yeah. It's 3 times normal. Normal is 100. So it's not acute pancreatitis until you're 300 or more. And it's diagnostic. It's pancreatitis. If you're not sure clinically, if we're not sure clinically, if they've had a perforated ulcer, because we used to see a load of those in the past, then an erect chest x-ray will tell us the difference. And we need to assess the severity, mild or severe. Next step, once you've assessed whether it's mild or severe, and there's a fairly easy checklist to follow. Mild ones, go to the ward, nausea and pain relief, IV fluids, eat and drink as tolerated. Severe ones start off the same way, but fluid balance becomes mighty important because they lose, it's like having a burn inside your tummy and you lose loads of fluid inside. And you might need 6 litres of fluid, in large volumes. We tend to put them in the by mouth because they're often vomiting. They need at least hourly observations, and actually they should all go to critical care for monitoring. Daily progress is not measured by serum amylase. Once you've diagnosed pancreatitis, you can forget your amylase. Daily progress is monitored by watching your white count, watching your liver function tests, your electrolyte balance, and CRP, because CRP will go up and you want to watch it coming down as the pancreatitis gets better. Search for a cause. We've talked about alcohol, you'd get that from the history. Ultrasound scan for gallstones. High calcium can give you pancreatitis, as can high lipid levels, so fasting blood test the next day, easy. You go through the drug list. Some drugs, for example steroids, can provoke acute pancreatitis. Viral, some infections can spark off pancreatitis. Gut ischemia, but I think you'd know about that from other investigations. Malignancy, particularly widespread malignancy. Inflammatory bowel disease, and at the end of the day, there are 10% where we just don't find a cause. So the majority should have a cause. And from the patient's point of view, when can I go home? When pain is controlled with oral analgesia, when you're tolerating diet, when that CRP is coming down, and a plan for your cholecystectomy if you've got gallstones. So it's quite simple, it's not rocket science. And because I got a bit frustrated doing my surgical ward rounds where acute pancreatitis has come, I devised, I'll show you in a minute, very simple. It's not quite a flow diagram, but it's close. With all those boxes on about sorting out acute pancreatitis, and then how you score it, and the references are on the back. Talked about antibiotics, that's one of the frequently asked questions. CT, the role of CT. CT is no good for looking for gallstones. It won't tell you if somebody's got gallstones frequently. And it's only useful if you're not sure what the diagnosis is at presentation. It's really useful at day 5, because if you've had nasty pancreatitis and your CRP is not falling like you'd hope, then they could have pancreatic necrosis. And by day 5, you can demonstrate it. if you do it on day 1, all you see is a lot of swelling around the pancreas, and it doesn't really help you. So if you've done it on day 1 and they're not getting better, you need to repeat it on day 5. And that's a radiation dose for the patient. So there's the references. And as with all guidelines, clinicians are free to manage patients however they wish, as long as you write it in the notes as to why you're giving them antibiotics, or as to why you're doing a CT scan, or as to whatever. And again, that doesn't show well, but it's that bit of paper. Right, okay. So I will put it to you, in the 21st century, not one of us, no matter how clever, can retain all the facts in our head. It's just absolutely impossible. And guidelines, just like all those ones I showed you, act as an aide-memoire. They remind you how often to do your head injury observations. They remind you how to manage your central venous line. And it's a minimum standard that we should be achieving. And I put it to you, we can also use them as a communication tool. It's between staff, so I could say, just look at the guidelines for acute pancreatitis. We expect a bit of a temperature. We're not going to give them antibiotics. If you really want to check that out, look at the references. And how does a patient know when they're going home? That's often one of the first things they ask, or certainly within 24 hours, is, when can I go home, doctor? And we need to share them. Share our guidelines with patients and their relatives, so that they can see, and they will also then see if they're falling off their perch and not getting better, and they'll understand that things have not gone exactly how it should have gone, or we'd hoped. So I've got a question for you. Why do clinicians not like following guidelines? I don't understand why they do, but most of my colleagues do not like following guidelines. Steve Evans says the same for the stroke pathway.
Is it sometimes that they have quite, in order to do your job, you have to feel that you're quite superior, possibly, for want of a better word?
Yeah, for want of a better word, absolutely, yes. I'm a doctor, I know it, yes.
You know it all, and you're confident in your own knowledge, therefore you don't need the guideline.
Yeah. But to me, it would make life so much easier, going back to that 80-20, if the routine stuff, so routine pancreatitis, clockwork, got it? I can concentrate on that chap with the septicemia, where I don't know where it's coming from, who's got the low blood pressure and needs a bit more personal time from me. It seems to be a problem the world over.
Is a problem the world over, or do you think it's... Because I think in Guernsey, where we just have a consultant clinical body,
yes,
that's slightly different than if we were in the DGH, where you probably start off with the health officer and
who would be more amenable to using guidelines. And actually, having those layers of staff, they're more prepared to ask questions. So if the consultant arrives and says, I think we should have antibiotics, they could say why. Whereas it's much harder for the nursing staff to challenge, isn't it? So I think there is a degree of that, absolutely. And you know, I think it is difficult in Guernsey. Steve, any comment? Yeah.
It's very difficult.
Yeah.
Do you see the same in private healthcare? That's perhaps only consultant.
I think no, absolutely, Ryan. I think you're probably right. Yes. Yeah, I would think so.
Do you think people understand that guidelines actually keep people safe?
No, I'm sure they don't, Juliet. I'm sure they
for me,
don't.
that's the main reason.
Yes, and I agree, and it provides a minimum standard of care. You might do something over and above extra, but it means that everybody gets that level of care, doesn't it? So I was frustrated one day when we were down on Brock. And Moira, what's Moira's surname? Norman, yeah. She saw me being frustrated. She said, Carol, the obvious thing to do is to audit it. Is to look at acute pancreatitis and how we manage it in the hospital. So this was done by Nick Dove. I've badgered Nick no end. myself and Rob Kiff. And Nick realised that we can identify acute pancreatitis in the absence of medical coding by a raised serum amylase. Of course we can. So he trotted off down to the lab and asked for all values over 300 and above, so more than 3 times normal, where you might reasonably expect acute pancreatitis to be the diagnosis. Of course, the lab system doesn't talk to track, and the patient identifiers are different. So he ended up going backwards and finding the patient numbers. And then Rob and I trawled through the notes. Nick did what he could from track. And we did 2 whole years, 2017 and 18. And we pulled the notes and reviewed them. We did define it as people who were admitted with that diagnosis of acute pancreatitis. So, for example, there was someone admitted with ischemic bowel, and that was their main diagnosis. The primary diagnosis had to be acute pancreatitis, and they had to be admitted. It's interesting, there's a number that don't come into hospital. And as a result, we got 43 cases, or we reviewed 43 case notes. There were a few that were missing or had passed on over that time. So all the ones that we reviewed. And the serum amylase ranges from, as you see there, 392 to over 5,000. And I think it's important to realise that the higher your serum amylase is, it does not reflect how severe your pancreatitis is. It just tells you you've got acute pancreatitis, and it really doesn't matter what that number is, as long as it's over 300. And documented in the medical notes, 8 were mild, 3 were severe, and 32 there'd been no assessment at all. Length of stay in days, and this fits in with what you might expect. Mild ones, majority, shorter length of stay, and then a few more severe ones out the other end. 18 of those 43 were given antibiotics. So no reason was given for 6. Acute cholecystitis, well, if you've got gallstones and cholecystitis, that might be acceptable, mightn't it? So a reason. Severe pancreatitis 2, no, severe doesn't get them unless there is evidence of infection. Uncertain diagnosis. Don't quite know why it's uncertain if you've got a raised serum amylase. I can't remember the post-op details. One had a CBD stone, a common bile duct stone, so I think they're probably thinking of ascending cholangitis for that one. One, it's because the physician said, and one is documented the temperature was 38.2. CT within 24 hours of admission, there were 12, and the reasons given, well, let's start at the bottom. One was known to have a diagnosis of a lymphoma, and they wanted to assess disease progression on admission. One was documented as having severe pancreatitis. 3, they didn't know what the diagnosis was, and therefore that's an indication for an early CT. And 7, it was either the doctor's preference or no reason was stated. We probably could have saved those 7 at that stage. And the cause of the 43, 27 had gallstones, of which, as far as I can make out, only 12 underwent subsequent cholecystectomy, and certainly not within 2 weeks. I think there was 1 that was done same admission. The reason for not doing it is obviously if you're elderly, infirm, comorbidities, but it's hard to believe that, well, do the maths, 7, 8, whatever, didn't have a reason for surgery. There's one gentleman I've actually chased up. It was his second admission with acute pancreatitis, and he wants his gallstones dissolved. Well, they don't dissolve very well at all. And he was listed for surgery but never showed, and there's no record of him thereafter. So he's still out there waiting for the next bout of pancreatitis. I suspect we've just not sold it as why you should have it. Only 4 were alcohol. I thought there'd be more alcohol-related ones. Acalculus Cola Society. Then we've got the oddities, haven't we? Papillary, that's the ampulla of Vata, where the common bile duct comes into the duodenum tight. Viral, hyperlipidemia, and 8 of the 43 were labelled as idiopathic. Now, to my mind, we haven't searched for a diagnosis in those, because once you get beyond the top 2, surgeon's brain tends to switch off. And really, we should go down that list and really try and exclude a cause, because obviously you can get it again if we don't know the reason for it. So there we are. I don't think we measure up particularly well to our set standard. I have no idea what to do about it. But I would like you to, when you leave here, go away and think about your set plays. And if you can make it routine, this is how we do it every time, then it will actually save you a lot of work and a lot of brain power and talking. We just do it, and that's the way to do it, and it's evidence-based.